Hello, my name is Leivy Reyes Morel, and this is my DNP project presentation on sleep promotion in the ICU to prevent delirium. I want to take some time to thank my committee members who helped me through the development of this project, started with the chair, Dr. Jody Green, the second reader, Dr. Rita Wunderlich, and community member Eileen Rayvert. Background. The topic of interest was delirium, which is a hospital-acquired condition that is characterized by acute change in mental status. It affects at least 80% of patients admitted to the ICU. This can prolong their hospital stay. It adds to the cost of diagnostics and treatment, increasing their overall cost of care. My initial search, I found that delirium is multifactorial, and there are modifiable causes that are being overlooked, such as sleep deprivation. Significance. Delirium is detrimental for a patient, which has impacts on the nurses, on healthcare systems, and advanced practice providers. Nursing, for example, have to utilize different types of knowledge to understand the causes and effects of delirium. This project reinforced that knowledge and provided the means for them to act appropriately in the treatment and prevention of delirium. Healthcare systems must consider the negative impact that delirium has on patient outcomes and the overall cost. They must adopt policies such as the one that I proposed to mitigate those effects. Advanced practice providers must use their knowledge and skill to improve patient outcomes. This project encourages collaboration, advocacy, and the use of evidence-based practice to achieve that. Purpose. I aim to promote a practice change in the ICU regarding delirium prevention and sleep promotion. My purpose is to increase adherence to the proposed intervention, which is sleep promotion practices. I created a sleep promotion protocol and educated the staff accordingly. Literature review. Literature review began with database search using CNOL, OVID, and Data Search Complete. Search phrases included delirium, delirium management, pharmacological interventions to prevent delirium, non-pharmacological interventions to prevent delirium, interventions to prevent delirium, sleep promotion in the ICU, and the like. I included 13 articles for this article review, which had some limitations. For example, there were no high-quality RCTs, and most of the interventions that they recommended were not uniform. They varied from article to article. This affects the applicability of their recommendations. However, I was able to classify what I found into 3 themes. The first theme is that delirium has negative outcomes. There are patient-specific outcomes such as increased morbidity, mortality, prolonged hospital stay, increased risk for falls, interruption of treatment, removal of lines, etc. There are healthcare effects such as increased cost, staff burnout. Second theme, modifiable risk factors for delirium. There are patient-specific factors such as dehydration, nutrition, infection, hypoxia, sleep deprivation. Most of them are not addressed adequately. The most ones that are addressed are dehydration, hypoxia, and infection. Nutrition and sleep deprivation at the bottom of the line. The ICU environment is a modifiable factor. This environment is noisy, there's a lot of lines, use of restraints, mechanical ventilation, and more noxious stimuli. Nursing care is a modifiable factor. Nurses can provide reorientation and provide us environmental changes. The third theme is that there are effective nurse-led interventions for delirium prevention and management, some of which can be classified into environment manipulation, coordination of care, cluster of care, and sleep promotion. Theoretical framework. The theory that reflects the goal of this project is that one of Levine's conservation model. The goal of this model is, and I quote, to promote adaptation and maintain wholeness using the principles of conservation, end quote. Patients who are admitted to the ICU, they are critically ill, and they have to adapt to this new environment and the changes in their body. This is where some of the concepts that I selected, such as prevention, intervention, adherence, and outcomes, come into play. From this model, there are certain concepts that apply to this project, starting with the conservation of energy. When patients have a restful night, they can restore that energy to maintain their wholeness. Physical integrity. Some of the proposed interventions, such as sleep cycle interventions, mobility, adaptive equipment, help maintain their physical integrity. Emotional integrity. Non-pharmacological interventions such as touch relaxation techniques, calming measures, help restore their emotional integrity. Social integrity. When nurses provide reorientation and include the family in this plan of care for sleep promotion, it helps maintain their social integrity with their family and their loved ones. Environment. This protocol uses various interventions to manipulate the environment to ensure the patient gets a restful night. Methodology. The project design is an exploratory qualitative pre- and post-study. I obtained IRB and DMP approval from the facility from Morel, and they granted exception because of the nature of the study being a quality improvement project. This was followed by staff education. They were educated on sleep promotion practices from the PADIS guidelines of the Critical Care Society. Later, EMR augmentation was changed to create documentation of sleep promotion and the protocol order for the nurses in the documentation. Data collection occurred through retrospective chart review. There was the identification of data to ensure, as well as other ethical considerations to protect patient information. Sample. The setting where this project was implemented was a surgical ICU at a level 1 trauma center in a hospital located in eastern U.S. The participants were adult patients admitted to the ICU, and there were 141 patient chart review for this project. Sample criteria. Inclusion-exclusion criteria. Patients included for review included those who were admitted to the ICU, were 18 years of age and older, had an ICU stay longer than 24 hours. Patients excluded were those who had an admitting diagnosis of stroke and traumatic brain injury. Data analysis. Descriptive statistic was used for patient demographic, such as mean, standard deviation, and percentages. Nominal data was collected, such as yes and no, labeled on the data collection sheet, and they were either number 1 or 2, 1 for a yes, 2 for a no. I used a C-test for 2 variable because I wanted to see if there was any change in one direction. And the tools that I used with the help of Dr. Powell's Morel statistician were the SPSS statistic tool and the Excel statistic tool for the demographic data. Data collection. For this project, I created a data collection sheet and recorded the documented interventions such as noise reduction, light reduction, cluster of care, pharmacological interventions, and non-pharmacological interventions. So this tool cannot be validated because this was created specifically for this project. Other patient data documented, collected was their age, gender, length of stay, and primary team. Results. So we can see the results of the demographic data. For the pre-intervention, there were 76 patients. For the post-intervention, 65 patients. The mean age for both groups was in their 60s. There were more males than females for both groups. The mean ICU length of stay was greater for the post-intervention group than compared to the pre-intervention, but I did not consider factors such as admitted diagnosis and morbidity to see if this was statistically significant. Results of the intervention. The interventions recorded, we can see an increase in the use of all of the interventions. Both groups have some form of pharmacologic intervention such as sedation, pain management, but not sleep aid was documented while in their ICU stay for neither group. The most individually used intervention was noise reduction and cluster of care. Non-pharmacological interventions that were considered and recorded include massage, pillow support, music, warm blankets, but no eyes, earplugs, and or eye covers were recorded for neither group. Results. I calculated a C-test of 2 proportion, which showed an increase in the use of sleep promotion practices. This is statistically significant with a Z of 1.96, a power of 0, and a confidence interval of 95%. This means we can reject the null hypothesis. Analysis of the data. We can infer from the results that the proposed interventions are easy to implement. The demographics for both groups for the pre and the post interventions are similar, and there are some interventions that are used more frequently, such as noise reduction, light reduction, and cluster of care. This project had various limitations, which I will discuss further. We had to exclude some patients from the data collection, such as those who had traumatic brain injury, but they were not excluded from the intervention. There was contradicting existing protocols that were in place, and we had to work around it, so most of the interventions were not fully implemented on all the patients. We also had to consider the patient's unique needs for everyone. The staff was not blinded. They were aware of the purpose of the study, and there was no randomization for this project data collection. Some of these factors obviously affected generalizability for this project, but it's possible if we utilize a similar environment with similar patients. In my plan for sustainability is continued education, reinforcement of the effects and the positive outcomes. Also, some chart audits annually can be done. Implications for research. This study did not measure the effects of sleep and quality, so researching on that would be helpful to see how these interventions affect the quality and quantity of sleep. Also, we can find what is the nurse's view on the interventions and their effects on the patients. We can also see what are the long-term effects of the interventions on delirium development, such as delirium incidence. Implications to practice. The results show an increase in the use of evidence-based practice. This can increase autonomy and nurse satisfaction. The hope that if we continue to use them is that the patient outcomes will be improved, quality of care, safety, and patients, nurses, and family satisfaction. Conclusions. The results show that the use of EBP is possible. But to achieve this, we must provide educations and appropriate tools to the key stakeholders, such as the nurses. The collaboration is with family, providers, patients, ancillary staff is key to be able to achieve such interventions. And other conclusion is that there is no one specific intervention to promote sleep, so we have to use a bundle of interventions to be able to achieve it, considering each patient at every time. This is the end of my presentation. I'm open for questions, and the rest of the slides are my references. Thank you.